An unprecedented level of knowledge about human biology, which accumulated at the beginning of the millennium, has enabled the dynamic development of microfluidic systems, as you all probably know. Now, Linda Griffiths' labs and Don Ingber's labs pioneered the single organ on a chip development, whilst Michael Schuler's lab and our labs at the Technische Universität Berlin pioneered the multi-organ chip developments as illustrated here. We at the TU Berlin set the concept for the creation of an in vitro equivalent of an individual's body on chips from 2007 onward. That is like this paper here. To develop the concept, I teamed up with a number of professors of different disciplines, and the first public exposure of our concept was an invited presentation at the Royal Society in London in 2009. Here is a key slide I used at that time to explain that the preclinical test dilemma can be solved ultimately if science can deliver a human mini organism on a microfluidic chip. Indeed, a 73-kilogram human body consists of a bit more than 10 to the power of 13 cells, representing 224 cell types, assembled into approximately 60 organs, and they all belong to the 10 biological systems which are highlighted here. If you supply 2,500 kilocalorie energy per day to such a body, you all know you can remain that body alive and healthy over an entire lifespan. Now, the hypothesis is that the physiological integration of at least 10 key organs on the microfluidic chip enables a minimal self-contained organismal homeostasis. That's why a human body on a chip is now defined as a miniature, mindless, emotion-free, self-contained physiological in vitro equivalent of an individual, mature human body. To underline that, we coined the term organismoid for such an envisioned solution. Much like the term in vitro organoid now stands for a tiny self-organized in vitro replication of a single organ. We expect the first proof of concept to happen in the next decade. Now, three fundamental working principles underlay this vision. Firstly, all human organs are built up by multiple, identical, functionally self-reliant structural organoids. Secondly, such physiological organoids are evolutionarily conserved and subject to genetically encoded self-assembly. And thirdly, vascular perfusion, a connective tissue bed, and organ-specific stem cell niches are essential features of any of these miniature functional units in our body. Your today's breakfast has been absorbed by approximately 7 million intestinal villi, is currently metabolized by 1 million liver lobuli, and you will excrete waste products of your breakfast through 2 million kidney nephrons somewhere in the afternoon, hopefully. How small can we downscale a human body? We at the TU Berlin decided on a downscale factor of 100,000 and published that rationale in 2012. In this case, your body still consists of 10 liver lobuli on a chip, which allows 30% of them to be damaged and regenerated without the liver model losing its function. This number of liver organoids requires a corresponding number of functional units of the other at least 9 organs to emulate a minimal, functionally independent human body on a chip, as illustrated here. In 2014, our engineers translated that into a 10-organ chip design. And I will show you their video. Let's take a closer look at the human on a chip. This chip generation has an area of a standard glass microscopic slide, and it consists of 4 layers: an adapter plate, a nutrition plate, an organ plate, and a sensor plate. Now, a common blood vasculature interconnects the different organ models, such as the intestine, the liver, and the pancreas. Nutrients are absorbed by the intestine and distributed by the circulatory system. Insulin and bile is produced by pancreas and liver respectively. Food which is not absorbed is excreted. The kidney filters waste, excess ions, and chemicals from the blood to form urine. Additional organ models on the chip include the lung, the bone marrow, skin, adipose tissues, brain, and testicles. Now, with that arrangement, substances can be applied intravenously by direct injection into the circulation. The transparent sensor plate allows the electrical coupling of organs and microscopic access. Now, if you assemble the entire system, substances can also be topically applied onto the skin. Oral uptake and inhalation can be emulated respectively. Finally, the chips can be run fully automated over extended periods of time by employing state-of-the-art robotics. Such organismoids are supposed to be sufficiently flexible for diverse disease modeling and to bear the potential of ultimately replacing animals for systemic substance testing. Michael Schuler's labs and Linda Griffith's labs evolved toward MPS, integrating 10 and more culture compartments in a single chip format, and Linda has shown some of the examples just recently. They each use different cell lines and cells to test their prototypes in a 1 to 4 week co-culture experiments. I have highlighted the remaining technical challenges which they and we as an entire community are still facing with MPS. And I don't want to go through all of them, but another organismoid-specific biological challenge became apparent. All organs should be derived from one donor for a functional, immunocompetent human body on a chip, otherwise rejection will occur in the systems. Therefore, for our first organismoid prototype experiments, we established the background to derive all cells and organoids from single donor iPS cell banks. This approach reflects the fourth principle of our organismoid concept, the accelerated terminal differentiation of premature organismoids, enabled by in vitro training programs for organoids and enforced by organismoid-based on-chip crosstalk. In more detail, we aim to emulate the ontogeny in humans, here highlighted in yellow, shortened to few months in the generation of healthy adult body replicates physiologically functional for long periods. They can then be utilized to emulate acute, subchronic, or chronic disease periods of an individual to precisely select the best fitting therapies for that particular patient. In the multi-organ chip universe, we have first proofs for iPS cell-derived tissue maturation due to on-chip crosstalk for bone and liver models in the respective 4-organ papers of Jordana's group, which has been presented 2 days ago, and from our own research. So we established qualified, internationally registered, and published 6 commercial integration-free iPS cell banks. Subsequently, robust differentiation protocols have been developed and generated for 10 types of cells and organoids from a single donor bank. Okay, thank you. We integrated We integrated these into the Organismoid prototype chip and evaluated the 7-day performance. Immunohistostaining and gene expression analysis for key parameters have been performed, indicating stable homeostasis. We were able to stably endothelialize all microfluidic channels involved in the chip. However, similar to Michael and Linda, we haven't reached the final Organismoid level yet. I have summarized our remaining challenges here. The on-chip hematopoiesis in the bone marrow is still insufficient. The capillary endothelial network could not be fully interconnected within the organoids. Consequently, we are not yet able to produce whole blood on the chip and perfuse and circulate it into each of the organs. The differentiation of testicular and immune tissues is still ongoing. And finally, innervation and lymphatics should be considered. Now, our humimic multi-organ chip platform currently consists of protocols to establish 16 human organ models, as you heard in some other presentations here. Based on our Organismoid design, we reverse designed much simpler universal chips of the same standard geometry to host 1 or 2, 3 or 4 organ models of any lower level of biological complexity, using always the same benchtop and automated equipment. 22 assays have been established at different levels of qualification yet. And we aim to use this specific knowledge from that different assays here to generate at this lower level of biology the remaining biological information to solve the challenges. I highlighted the respective programs adding missing information for the Organismoid solution here. As an example, we recently managed to improve our autologous 4-organ chip. Now here they downstairs, difficult to read, I think. But I will give you a short glance on that. This physiological-based pharmacokinetic compliant IPS-derived 4-organ chip has been published a couple of years ago, but it lacked an endothelial blood-brain barrier. Now we have improved its performance by adding a functional blood-brain endothelial barrier differentiated from the same donor. That was an internal proof that the maturation of such a barrier can be exercised within an acceptable time frame. The BBB-specific endothelia have been cultured at the opposite side of the porous transwell, as you see here, membrane of the neurosphere compartment. High TIA values and biomarker analysis pointed to BBB-specific endothelial properties. We benchmarked the functionality of the barrier independently, applying 3 drugs which expose low, medium, and high BBB permeability, respectively, in humans. A single exposure regimen at day 5 of the co-culture of the BBB-containing 4-organ chip has been performed and terminated at day 7 after 48 hours. Drug levels reached equilibrium within 48 hours in the 4 separated biological compartments of the chip: the intestine, the surrogate blood circulation, the brain, and the kidney circuit. Among others, the blood and brain data here shown with red and green arrows perfectly matched the behavior of those drugs in patients. They displayed low permeability for atenolol, medium permeation for carbamazepine, and free passage of verapamil at the end of the 2-day pharmacokinetic profile. These results added a functional blood-brain barrier to the autologous PBB key-compliant chip, and the human 4-organ model is now ready to support ADME profiling, PK studies, and toxicity assessment. It further enables disease modeling, including the immuno-oncology domain, at a new level of human biology due to the autologous nature of all organs. Okay, let's come back to the Organismoid topic. How can they add value to precision medicine? Now, when doctors diagnose a tumor in patients, they eventually can use Organismoids to select the most appropriate treatment plan for the patient if they have available iPS cell bank. Therefore, for example, a set of identical 24 identical healthy organismoids of that patient could be generated in qualified test facilities. Then a specific number of organismoids are loaded with patient tumors, and various treatment regimens proposed by the physicians are then tested in the humic autolab. The earliest, most appropriate result triggers the transfer of that particular treatment regimen to the patient. This should result in a comparable curative effect for the patient at best. Now, such chip-based precision medicine is characterized by a number of outstanding new features. For the first time, biological replicates of patients' bodies are available, which we do not have in clinical trials. This is expected to significantly increase therapeutic precision. In addition, the healthy body controls will optimize monitoring of remission. Normally, you don't have healthy body controls. Access to every tissue in every organismoid during the tests will provide previously impossible insights into disease progression. The approach is also suitable for mimicking clinical trials in the preclinical setting. As I mentioned, the community expects to see the first proof of concept not earlier than in 2030. At the end of my presentation, I would like to be crystal clear with the limits of MPS-based platforms. Due to its miniature size, an organismoid on a 3 by 7 centimeter chip cannot properly emulate the fracture of a large bone or precisely recreate the impressive pumping performance of a 300-gram heart. By definition, it also cannot model disorders of consciousness and mental illnesses where the entire architecture of the 1.3 kilogram brain is required. Given all that presented information, I envision future MPS-based automated test centers to become the core solution for preclinically informed development of new drugs and advanced therapies. Such platforms will enable individual treatment schemes best fitting for individual state of the disease and at a particular moment of your life. Furthermore, you-on-a-chip solutions will be able to predict health-promoting diets and cosmetics on an ethnic, gender, and even individual level in the future. And there are other consequences beyond healthcare. I expect the laboratory animal studies to be cut by at least 75% through implementation of such robust solutions, and product development will be also optimized in the future. That said, I would like to thank our team for its incredible impact and thank our partners for running that technologies too. Thank you for your attention.
All right, thank you very much for this presentation. Other questions? Please raise your hand. I'm going to run. Okay, well, everyone's thinking about a question. The scaling, do you apply that also to your media? Do you go from, I think, 5 liters of blood down to about 50 microliters of? 50 microliter, yeah. We are scaling down all biological parameters, more or less, and that allows us then also to scale to have a direct in vitro to in vivo extrapolation.
I have a simple question about the vasculature. Do you use tissue-specific vasculature for all the organs? Because I saw for the blood-brain barrier, I was wondering, you do the same for kidney and intestine and everything?
We are developing from iPS, we are differentiating the endothelial cells for a number of genetic processes, and then adding that. We were expecting that they become organ-specific in the organs, but for the blood-brain barrier, we need the external pushing them to the blood-brain barrier characteristics.
Thanks. And related to the same question, are you able also to modulate the shear stress in every tissue differently? It's like the vascular shear stress, it's physiologically relevant in each tissue. Thanks.
Self-organization and right microfluidic flows will do that. So the shear stress is is dependent upon the fenestration of the endothelium in those organs where they are fenestrated, which are only few. And in all the others, the shear stress is defined by our flow, and that is a physiological pulsatile flow.
Hey, Avi, very nice talk. Have you managed to make all the media that you have serum-free at this point?
Yeah, we do have medium serum-free medium for the 4-organ chip, and for all 4 organs important, and that has been shown by others too. Important is that you have the barriers in place, because the medium in the circulations are then other and start to become other than these in the apical part of the intestine or in the urine, definitely, and in the brain fluids. We add human serum sometimes, or human albumin to that media, but the system produce their own proteins by the liver.
Thank you. And for the scaling problem again, if you have drug concentrations or molecule concentration extremely low, how you'd solve that problem? Will you use like parallel organ on a chip units, or how that can possibly be solved?
Oh, very good question. We try to go exactly through how the patient is doing it. So if it has a three times a day tablet, we downscale this tablet to 100,000, the concentrations, and give it orally, like in this case, on the intestine. If you cannot make that concentration with 1 or 2 drops, you start to deliver the drops over 5 minutes, because in the intestine, you anyway have some time to get the drugs to the intestine. It's not a gastric, but a post-gastric application.